Tips and tricks to optimize ultrasound imaging of recto-vaginal endometriosis. This is a video presented by the minimal invasive surgery team at the Laval University Hospital, in which two possible techniques will be discussed that will help you improve your assessment of recto-vaginal endometriosis. Endometriosis is a disease affecting about 10% of reproductive-aged women. This accounts for a total of 190 million women worldwide, according to recent WHO estimates. It is a benign yet very invasive disease, which has been under-recognized for a long time, even within the field of gynecology. Especially the need for expertise imaging has led to and still leads to important delays in diagnosis. The average delay of diagnosis is between 7 to 10 years, meaning that patients are often diagnosed when they already have extensive disease, presenting not only with severe dysmenorrhea, but often already in a stage of chronic dysfunctional pain and/or infertility. A very common presentation of women presenting with deep infiltrating endometriosis is the presence of recto-vaginal nodules, often missed on routine imaging studies. Our goal is thus in this video to improve our transvaginal ultrasound technique to be able to better evaluate the presence and extent of recto-vaginal endometriosis. We will discuss two techniques that can be used to optimize your standard transvaginal ultrasound imaging. The first one being what we call Vaginal Gel Sonography, in which we create a gel plane between our ultrasound probe and the vaginal wall to allow us for better evaluation of the vaginal wall and the presence of potential endometriosis. The second technique is what we call Transvaginal Rectal Hydrosonography, meaning that we will inject water into the rectum while performing a transvaginal ultrasound. The water will create a plane, which will allow us to improve the distinction between the rectal lumen and the rectal walls. It allows us to clearly see the different layers of the rectum and allows us to better estimate the intramural extent of a rectal nodule. The transvaginal approach allows us to work in a way that we are used to, working in the field of gynecology, and is thus easy to learn. Additionally, it allows us to evaluate the relationship of the nodule compared to surrounding structures, like the posterior vaginal fornix, the uterine torus, the uterosacral ligaments, and the ovaries. We will start with the ultrasound appearance of normal vaginal and rectal tissue, and then secondly, we'll discuss our two techniques in detail. For the ease of the video, I will describe shades of white and gray to describe the different layers, understanding that white means hyperechoic and dark means hypoechoic. On ultrasound, the vaginal mucosa will appear gray. The thickness will depend on estrogen status. When reaching the posterior fornix, we note the millimeter-thin white line of the overlaying serosa of the Douglas pouch. Note that there are no irregularities of the vaginal wall. The serosa, or outer layer of a normal rectal wall, as seen in this image, is identified as a white millimeter-thin line, followed by a thicker dark gray muscularis propria layers. Underneath the muscularis, you will find the lighter gray submucosa and ultimately a thin white line depicting the mucosa. So how to improve our visualization? Our first technique is a vaginal gel sonography. For this technique, we need only two things: a routine large examination glove and an ultrasound gel that does not contain air bubbles. We will introduce a large chunk of ultrasound gel into the thumb of the glove to fill up the entire tip. The goal is to have a large mass of gel between the probe and the glove tip. Because the material of an examination glove is more rigid than the routinely used ultrasound condoms, the gel plane is preserved better and allows for better visualization of vaginal nodules. We always start our exam with the evaluation of the posterior vaginal wall and fornix. The most important part of the examination is to introduce the probe very slowly, scanning sagittal, focusing on unrolling the posterior vagina until reaching the posterior fornix. Generally, endometriosis nodules will make the vaginal wall appear thickened and uneven. They generally consist of a darker gray. In this video, you see a dark gray hypoechoic rectovaginal nodule. Note the irregularity of the vaginal wall. It also infiltrates the underlying uterosacral ligament and reaches even the muscularis layer of the rectum. This video shows the same nodule, but without the gel. Note how it is more difficult to pick up on the vaginal irregularity, making it harder to identify transmural disease without the gel. In the second part, we will present the transvaginal rectal hydrosonography technique. For this technique, we essentially need four things: a 60 cc syringe with a cone tip, Luke tap water, a bowl to contain the water, and a lubricant gel to apply to the tip of the syringe upon inserting it into the rectum. Pre-examination, a saline enema can be used about 3 hours prior to the exam, but it is not obligatory, mainly to consider in patients with a history of constipation. We start with rectally injecting a total of 3 syringes or 180 cc of water. This can be done by the patient herself or by the provider, depending on the patient's preference. We will then return to the transvaginal ultrasound. Just as for the previous technique, it is important to slowly introduce our probe. Following the rectal windings, try to notice if there are any signs of thickening of the rectal wall or extreme folds while scanning through. This is another case in which you see nicely the different layers of the rectum. In this fragment, we did not yet inject the water into the rectum. We follow the windings. At some point, we suspect a thickening, but it is difficult to have a clear image on whether or not the muscularis layer is affected. This is another fragment of the same patient, but after the water injection. It allows for a better visualization of the lumen, and in this case, we do have a clear visualization of the nodule. Note how it infiltrates the muscularis layer. Here you see a second case of an important rectal nodule affecting all layers but the mucosa, in which the water injection allowed us to easily see the extent. The ultrasound image correlates perfectly to the image of the specimen after bowel resection. Note how the mucosa is intact. Finally, we asked our patients how they tolerated this exam. All of our patients so far said that they preferred the ultrasound examination over the MRI. Even if causing certain discomforts, the fact of having live feedback about their condition and having the interaction with their healthcare provider had their preference. So in summary, we think in general that the alertness for correctly diagnosing endometriosis should be improved. Improving our ultrasound skills is herein a powerful tool. Transvaginal ultrasound is easily accessible and well tolerated. For diagnosing recto-vaginal endometriosis, the two techniques of vaginal gel sonography and transvaginal rectal hydrosonography are particularly useful, as they are cheap and require minimal material, are little invasive, are easy to learn, and allow us to improve our diagnostic accuracy. I would like to thank my entire team for the cooperation on this video, and thank you for your attention.